Katie Cooper. I'm the Regional Faculty Lead for Advancing Practice. Welcome to our first East of England Primary Care Advanced Practice webinar. So today the programme starts that I'm going to just introduce the work that's been happening at the Centre of Advanced Practice and the Regional Faculty Lead faculty, and then I'm going to just explain what is advanced practice, overview of the National Directory and the accreditation routes onto that, and then the funding that's available via HEE to enable trainees and advanced practitioners. Then we have the lovely Julia Taylor with us today, and she's just going to look and explain the different routes to become an advanced practitioner, help on how to evidence capabilities against the national frameworks, and just discuss the frameworks that are relevant to primary care that have now been released. Now, we do have apologies. The practitioners that we were going to have to give a couple of case studies have pulled out, unfortunately, last minute. So Marie Honeyfield, who is our primary care ACP lead, has kindly offered to just introduce herself and give you a bit of detail about her role. And then we're going to have plenty of time and opportunity to actually have a question and answer session. So we can kind of go through what's happening in practice currently, answer hopefully as many of your questions as we can, and just help guide you through the advanced practice minefield that's currently out there at the moment. Okay, so I'm just going to share my slides. Okay, if someone could give me a thumbs up that you can see the presentation. Oh, I can't see that. So, yep, thank you.
Yes, we can.
It's a problem when you share and you can't see it. And I just wanted to go through that one. I know this was up originally, but just to let you know that this event is going to be recorded so that then we can pull it on the primary care and the ACP web pages going forward. What we will ask is, again, just because we're expecting quite a few people in the webinar, if you can keep your microphones and your cameras off, just to help with the technology aspects of this. And then we will be giving the opportunity to ask questions at the end. But again, because of the numbers, Cash is going to put in the link to Slido. So if you have any questions during the presentations or as we go along, please put them in there, and then we will bring them up at the end of all the presentations. So just to give you some background, advanced practice roles are not new, and it was clearly stated in the NHS long-term plan and the interim people plan how advanced practice roles will significantly help in meeting the short and long-term workforce demands and will have the ability to drive workforce transformation. But alongside this, we also know that advanced practice roles historically have been developed as a reactive service response. They haven't been planned and organised within departments, organisations, regionally or nationally, and this has led to huge disparities between the educational standards, the quality and level of supervision, the organisational structure and governance that support these roles, and also the level of competences and capabilities that practitioners are matching to. As I'm sure you're all aware, there are huge variations in job descriptions, job planning and pay bands. And although it was acknowledged within the long-term plan that advanced practitioners do play a key role, it did also raise concerns about the professional organisational liability of practitioners working at this level. So to overcome this, Health Education England established the Centre of Advancing Practice, and their aim was to oversee the workforce transformation of advanced level practice by establishing and monitoring standards for education and training, accrediting advanced level programmes, supporting and recognising practitioners, and growing and embedding the advanced practice and consultant practice workforce across the regions. So as you may be aware, currently there are over 300 advanced practice programmes nationally, and they are going through, or most of them are going through, the accreditation process with the centre. This will ensure that the HI programmes that are out there and that practitioners undertake map against the multi-professional framework of advanced practice that was published in 2017. It will ensure minimum standards, and it will ensure that practitioners who are then qualified should and will be able to map against the 38 capabilities outlined within that document. To support not only current practitioners, they're also developing an independent and supported portfolio route, which we'll go into in slightly more detail. And Julia will discuss about the more professional credentials that are being developed. So as well as having the more professional capabilities, it's about professional credentials that will also help to standardise practice going forward. And then they're also developing and plan to maintain a public directory of advanced practitioners, which I'll also discuss in slightly more detail. To support the centre, the regional faculties were developed. So there's 7 regional faculties across England. The aim of the East of England faculty is to lead and promote advanced practitioners as part of the workforce solutions, supporting service change and work with local systems to identify demand, commission high quality education and training, and to support the supervisory needs of our learners. So key to that has been ensuring a consistent understanding of what advanced practice is and what the role should entail. So it's ensuring that practitioners, organisations, service leads all understand the 4 pillars of advanced practice and what level advanced practice should actually be obtaining within organisations. We're ensuring that we have a robust commissioning framework and strategy, and we've developed 6 ICS AP faculties to ensure that APs are not only then mapping against minimum standards, but also that we start to have a robust workforce planning with APs at the heart of that. So not only in the traditional roles such as emergency medicine, ACCPs, it's about those non-traditional, but where the really transformational pieces could come in with the development of advanced practice roles, and obviously primary care is key to that as well. And then we're also looking at developing supervision guidance. So some of you may know that Deb Harding produced an excellent supervision, clinical supervision guidance for advanced clinical practitioners, and it is on the HE website if you haven't seen it. What we're now in the process of doing is making that operational. How do we ensure that supervision is at the right level for all of our trainees? And how do we support our medical workforce and our current and well-established ACPs to have the appropriate supervision to then train the new advanced practitioners coming through? So that work is being undertaken currently, and as soon as we have more information about that, we'll let you know. But we are planning to have one of the national conference sessions within our region will be on the supervision work that's being developed. And obviously the other thing and something we want to work with going forward is also the communities of practice. Advanced practice can end up feeling like you're working in silo, especially within remote practices, or just if you're in a profession where there's not a huge number or newly developing these posts. So it's making sure that we have a supportive environment going forward and that we start sharing best practice. And we will be looking at CPD. So not only are we looking at the commissioning of training and supervision, it's about how we support our current and established workforce to ensure that they maintain their skills going forward as well. So what is advanced practice? In 2017, as I stated, NHS England commissioned work specifically looking at defining advanced practice and the core capabilities that everyone with advanced in their title should be able to map against. This is important as it clearly set out to organisations and practitioners the minimum capabilities and level of practice that needs to be worked if working as an advanced practitioner. And this will enable us to develop the workforce that's not only sustainable but has transferable skills regardless of professional backgrounds. So within the definition, it clearly defines that advanced practice should be delivered by experienced healthcare professionals. It was a level of practice, not a job description. It's underpinned by master's level education and which is characterised by breadth of capabilities and competencies, not depth of expertise or specialism. Key principles include safe, effective, autonomous decision making in complex and uncertain situations within practitioners' own scope of practice. And going forward, all development of advanced practice frameworks and capabilities will be centred on the 4 pillars of advanced practice. And again, I'm sure you're all aware the 4 pillars cover expert clinical practice, leadership and management, research and evaluation, education, training and development. Now we know currently the majority of posts that have been created are focused on expert clinical practice. However, these roles for these roles to be recognised via the Centre of Advancing Practice and for practitioners to be added to the National Register, they will need to demonstrate that they are working across the 4 pillars in line with the Model Professional Framework of Advanced Practice. We are working with HI programmes, and again for accreditation they will need to ensure that programmes are blended to integrate the 4 pillars across the whole programme. And what I would say is for our current practitioners, I know Julia's going to touch on this later, if you feel that you are lacking or haven't been able to achieve across the 4 pillars, one of the current documents that's just been released is the CPD for advanced practitioners. That has a range of examples of how you can develop across the 4 pillars. There's a lot of organisational and NHS opportunities that cover the research, the leadership and the education and training. It doesn't all necessarily have to be MSc. So it's a really good document to look at if you're looking at how do I start to develop this, or how do I start to evidence that I have the 4 pillars within my repertoire. So as I've discussed previously, as part of the governance of advanced practice, the Centre has or is in development of Director of Advanced Practitioners. Now, just to be clear, advanced practitioners will remain under the regulation of their professional bodies, and they will need to comply to all of their professional codes of conduct as they always have done. But the Centre is going to maintain a public directory of individuals who have either completed a Centre accredited advanced practice programme, which I'll go into in more detail, or are able to evidence their education and clinical training and that it maps against the more professional advanced practice framework. From an East of England point of view, but actually nationally, we will be expecting all advanced practitioners, so anyone with advanced in their title, any trainees coming through, to either be working towards or already be on the register when it comes out for the national directory. And this will ensure that the minimum standards are maintained of those practitioners, and it will enable us to have a much more robust governance structure within the East of England, ensuring professional and organisational liability of these roles going forward. So the next question, I imagine, is how do you get on that register? So there are 3 routes in development currently, and the first one that we've touched upon is the HI accreditation route. Now this is for those who have very recently gone through an advanced practice MSc programme with a HEI. So we're generally saying from 2017 onwards, and all trainees going forward. So as and when the advanced practice programmes get accredited by the Centre, practitioners who undertake that course will automatically go onto the register, because as part of that accreditation process, the programmes will have to demonstrate the practitioners, no matter what pathway they take, will be able to clearly map and evidence against the 4 pillars of advanced practice. So from an East of England point of view, all of our HIs are engaging with this process. They are at different stages, and as you can imagine, if there's over 300 programmes, it's going to take a couple of years to go through this. But from the Centre at the moment, they're saying if you have undertaken or undertaken training from 2017, this is going to be the best route for you to kind of go onto that register, because the HIs will become accredited, the programmes will become accredited. Now, for someone like myself, who, should we say, did my master's a little while ago, and I won't fall into that time frame, there is then the portfolio route. Now, this is still in development, and it's been undergoing a feasibility study. So there's 2 routes. One is via the supported portfolio route, and this is one that we are going to be looking at in the first instance, because from the feasibility study, it showed that practitioners did have a higher success rate of getting on the register when they had that additional support of how to complete the portfolio. So we are going to be looking, and we're going through a tender process with the HIs to enable practitioners to have that support going forward to produce their portfolio and to then register via the Centre. The e-portfolio has been in development. We're hoping it will be out hopefully in September. This will enable you to record and upload the evidence. To go onto the Centre, it will have to be via the HE e-portfolio. But it will also enable you to map directly against the multi-professional framework or any of the credentials that have been, again, quality accredited by the centre. So you'll be able to map directly against those with your evidence. You can also use it for CPD. So it will enable you to continue to upload evidence against that. So it will have multiple functions going forward. The other route is the independent portfolio route. That will be exactly the same. It's just that as a practitioner, it's saying that you will be able to upload level 7 evidence against that and in that portfolio to get registered. Now, I would recommend that if you've probably gone through a credentialing or accreditation process previously, you're probably in a good position to be able to do the independent portfolio route because you've already done that previously. But we are waiting on more information. There will be guidance about the kind of evidence that needs to be supported as the e-portfolio gets released, and we'll keep you up to date regarding that. Now, the third route, and this is the one that conversations are being had, but is probably a little bit, maybe 1 or 2 years away, if I'm completely honest, with the conversations that are being had. What we are working with the professional bodies is that if they have an accreditation or credentialing process, if you go through that process, you will then automatically go onto the HE Advanced Practice Register. But to enable us to do that, we need to ensure that the credentialing process by the professional bodies maps against the multi-professional framework. We know currently they don't map directly as they stand, but the conversations are being had. It's actually very positive. Everyone agrees that this is the way that it needs to progress, and being credentialed by your professional body makes complete sense. But what we don't want to do is have duplication of work for practitioners. We don't want to make it so you have to then register with multiple places, but it's going to take a little bit of time, and currently the centre's priority is getting on the HI accredited routes for those programmes and the portfolio route. So the professional bodies will come, it's just going to take a little bit longer. So how are we going to support you from an East England point of view? Dependent on if you're a trainee or if you're already an advanced practitioner, these are the funding models that we currently have. So we will fund a full MSc programme, and there's training grants available to cover the cost of those. The one stipulation that we now have put in place is that you will need to either be in a trainee advanced practitioner role or an advanced practitioner. And the practices and organisations will have to, as part of the application process, guarantee that there is a job as an advanced practitioner at the end of the training. So one of the things that we've come in and found within the East of England is that there is a number of people who have gone through the training, but there are no posts at the end of it. And that means we're not utilising the workforce and the skills that they have. And practitioners shouldn't be working without a relevant job description and scope of practice, because they're professional and organisational liability. So we need to stop that process, and we need to make it more robust and ensure that if you're going through this training, because it is a 3-year course, that you can utilise those skills and you're actually in advanced practice role going forward. The second route is for that top-up funding. Now, this is for practitioners who may have an MSc in a clinical speciality or have done some MSc modules but not a whole master's. We will fund up to 100 credits. It must lead to a full MSc Advanced Practice Award on completion. Now, if it needs more than that, the organisations may be able to then make up the difference, or it might be that it's actually easier to do the full MSc and APAL what you have across. I suppose it's just being aware that most universities will only APAL up to 5 to 6 years prior to undertaking the new course. So this may be beneficial to those current practitioners who I'm fully aware that the governance has changed, and obviously the capabilities that now have come out may not have been there when you initially went into post. So this top-up funding is really ideal to identify any gaps that you might have, and then to be able to get that funding to ensure that you then are supported to enable to work to the full potential within your advanced practice role. And then finally is the portfolio route. So the portfolio route we will be scoping for in autumn. This is for current experienced advanced practitioners who can pretty much map against the 4 pillars of advanced practice. They will just be supported to enable that level 7 writing and ensure that actually the HI is happy that the evidence is appropriate to go onto the register. So in the East of England, we've got 300 places as a minimum to be able to support for this financial year, and then we'll need to see what's then available going forward. But again, we will keep you informed of how to enlist and join that scoping, and then how you'll then get linked with the HIs as soon as that information comes out to us. And then just to let you know from a training hub point of view and the funding, if you are interested, you need to ensure that your practice is supportive of this, and the practice will need to let the training hubs know their demand for funding for either the full or the top up. We will come out independently for the full portfolio route. So that's the link to HEE. It's via your training hubs to access that funding going forward. And then with the last slide, this is just our contact details. So we do have a mailing list. If you are interested, certainly within the portfolio route, I would recommend that you join the mailing list. And we do have an email. And then off the back of this, if you do have questions, or if you want to have a one-to-one to discuss where you're at, your pathway, how to develop the roles or the roles within an organisation, we have got planned 2 open sessions, one in the morning, one in the afternoon in early September. And the link is on the slide. So if you wanted to just have that time with the faculty, I think they're 15-minute slots, and we can just offer you some advice or support going forwards, then that is available to everyone. So that was everything I was going to go through, so I will stop sharing. There we go. It's very strange with everyone being quiet and muted. So what I will do is obviously we'll have questions at the end of the presentations, and so I will hand it over to Julia. But if you start putting your questions, if you have any in Slido, and again we'll come back to those at the end. But I'll hand over to Julia.
Lovely, thank you. I will try and share my screen now, Katie, if you can just tip me the wink, if you can see my presentation. I've got a whirligig at the moment, so.
Thinking about it.
It is. Something is happening.
Yeah, it's
fabulous, lovely, thank you. So thanks very much for inviting me along to speak to you over in the east of England. It's very nice speaking to you from the middle of the country in the Midlands. So my name's Julia Taylor. I'm an advanced nurse working in primary care for the last scarily 20 years. I'm also a GP trainer and GP training programme director, and have looked after advanced practice in Derbyshire for the last 7 years multi-professionally, and also involved with the HE National Primary Care team on all things advanced practice and supporting the development of the multi-professional team. So lots of variety in my job, which I really enjoy. So today I wanted to talk to you all about routes towards advanced practice, and to hopefully offer you some practical advice and guidance around developing a portfolio of evidence, which would hopefully support you along whichever route you want to go on your advancing practice journey. So as Katie has already mentioned, we've got the advanced clinical practice definition from a few years ago. And Katie's already mentioned a few key parts from this, but I obviously wanted to focus on the sections which talk about demonstration of core and area specific clinical competence and the ability of the advanced practitioner to be able to manage complex problems across a range of settings, being innovative, having those clinical reasoning skills, all of those things that we would expect from somebody who works at level 7. So remember that sentence about core and area specific clinical competence. So once the definition was out in the system, work has happened subsequently to develop various frameworks to support this. And you're probably all aware of many of them. Some have been profession specific. So we have the Advanced Clinical Practice Primary Care Nurse framework that came out the year before last. Some are role specific. Some areas have identified advanced practitioner roles. Some are setting specific, for example, primary care or secondary care, out of hours. And then we've got all the work that's happening around the credentials development that Katie's already mentioned. From a primary care point of view, we have been working hard to write the primary care core credential framework. And that framework identifies the knowledge, skills and behaviours that are required by all professionals working at advanced level in primary care. So regardless of your professional background, it's all those shared skills and knowledge and expertise that we have working in a primary care environment. So you can imagine there's a huge focus on personalised care, population health, shared decision making, just as examples. That piece of work will be become a credential. And as I say, the framework is written, it's just waiting for the work at the centre to look at how that credential will be measured. You have to think of a credential as a unit of learning. So they want to make sure that the way this is measured is aligned across all the various credentials. So there's lots of exciting things happening in the background. There's a few links I've included in the slides because I think it's always useful if you want to use them as a resource. These are the primary care frameworks that are available. I've mentioned the nurse one already, which is there. You're probably all aware of the roadmaps that have come out to support first contact practitioners that are coming into practice, but to give them a pathway so that they can go on and develop to become advanced practitioners if they wish to do so. We've got the MSK roadmap already out in the system, along with the paramedic one. And soon, hopefully next week, actually, the podiatry roadmap will be landing, closely followed by occupational therapy and dietetics coming along soon after. So most recently, the occupational therapists and dietitians have been working really hard to write their advanced practice capability frameworks. And obviously they had to get that in place before we could sort out the roadmap. So lots of things to align. I just thought it would also be good to mention that there are lots of other frameworks coming elsewhere so that we don't disappear into our primary care bubbles. And these are just a few of the ones that are outside of primary care. So we've got the mental health framework, which obviously is hugely relevant in primary care. So some practitioners might find that valuable to look at that. We've got learning disability and autism. RChem and FICM have been around for quite some time now. And quite recently, the surgical ACP framework curriculum was released, and that's available for viewing on that link. There's also a framework and credential coming for acute medicine. And the link at the very bottom there is the Skills for Health website, where you can find details of lots of others coming into fruition. So, for example, there's a framework for pelvic mental health as an example. So just hopefully a few links there for you. I think this is quite a nice diagram in terms of where advanced practice sits. And we can see that when we qualify as a registered practitioner, whatever our background profession, we're a novice practitioner, and it takes some time to build up our knowledge, skills and behaviours, and as we move through the levels of practice. We know that the definition talks about an experienced registered professional. There's a lot of debate about what experience means, but the thought is that around 5 years of experience is good before you step into that advanced practice space. You want to become proficient in your background profession before you step across onto that next level. It's not quite as simple. I always say, you don't go to bed one day as a registered practitioner. or an enhanced level practitioner and wake up the next day as an advanced practitioner. It's not quite that simple. There are areas of transition between the levels. So as you move across each level, you'll pick up skills from the next level across whilst not meeting the whole domain. So as an example, if we look at practitioners that have been working 3 to 5 years, they're doing very well in their fields. If we think about a physiotherapist, for example, and they want to step into first contact physiotherapy, they would sit really in this transition bubble because they've got the advanced skills in the clinical pillar and some from the so obviously evidence-based practice in the research pillar, but very much focused on the clinical pillar. And they would sit in this transition space in the middle, in that dark purple, but could build on those to develop capabilities across all 4 pillars to move into the advanced practice space. And we have work underway on the consultant framework also. So it's really nice to be able to see that there's a career progression for people in primary care. So I wanted to talk to you about the portfolio. Why are we going to ask for that? It's really around giving the opportunity for practitioners to develop a portfolio of evidence that's triangulated. So it's got various viewpoints, various people contributing, which we'll talk about later. And it pulls together those 4 pillars because we mustn't think of them as separate. We have to think of them as elements of advanced practice that are sort of intertwined. And the fact that once we get that sort of recognition and go on the directory for advanced practitioners, we can't stop, we keep on learning, and we have to embrace that lifelong learning as we go along. So having a portfolio under development will be really helpful, throughout your career, and will lend itself to your CPD activities as you go across. The other thing about the portfolio is that it wants to capture how you apply your knowledge, skills and behaviours in your day-to-day practice. So it's one thing going off on a module or learning about something on a course, but it's that ability to be able to apply things flexibly in your day-to-day practice. One of the things we talk about is capability more these days. You'll notice that the frameworks are very much called capability frameworks rather than competency. And this is really in a move to align to a lot of the medical curriculums and healthcare curriculums that are moving to a more outcomes-based approach. So it's about the application of knowledge. So if I can give an example from primary care, if I'm going to see a colleague of mine undertake a female genital examination, and I see that they've got the knowledge and they understand the anatomy and physiology and the procedure and the process of actually undertaking that examination, that's one thing. But I would like to know that they can apply that in a range of situations that they might come across in primary care. So they might be able to do a female genital examination on a woman who has never had children. Can they also do it on somebody who's had 6 children, on somebody with a prolapse, on somebody who's been a victim of sexual assault or FGM, somebody who's had a hysterectomy? So it's about being able to apply that in a range of situations so that you can provide safe and effective care for your patients. Let's move on. So the portfolio, obviously we've talked about evidencing capability across the 4 pillars, and we're going to look at the 4 pillars in a little bit more detail in a minute. But it's also really useful for you as individual practitioners to identify areas that you might want to develop or some gaps in your knowledge, particularly when you've been working in a setting for a long time and then the frameworks come out and we've suddenly got something to work towards. Katie's talked already about having almost a bit of a training needs analysis and looking at what support is needed potentially to help you meet that level of practice or the definition within the framework. So the portfolio can be really helpful for that. The other thing we wanted to do is to build people's confidence. It's all very well being competent or capable, but we want you to be confidently capable so that you get some job satisfaction and your patients get safe and effective care. Obviously, we are wanting people to work at the top of their licence and be really effective in helping meet service needs and public patient needs, obviously, as well. Very important. So here's a list of suggested contents. And as I mentioned earlier, it's really important that we have triangulated evidence. Many of us will have done modules or courses where we've maybe had to have a reflective portfolio where we've put information in that ourselves, and that's really important, and there's certainly a place for that in an advancing practice portfolio. But it's also really important to get feedback from a supervisor and from patients and from your colleagues, and that makes it far more robust in terms of standard of evidence. It'll also help to look at different parts of your work day to day and sort of challenge and support you as you go forward. So we're going to have a look at the clinical bits and bobs, but you can certainly see things like complaints and compliments, significant events, patient satisfaction questionnaires, and multi-source feedback from colleagues. And try and include clinical colleagues and non-clinical colleagues, because we need to be able to work as part of a multi-professional team with clinicians and non-clinicians, and it's very telling. It's certainly within medical education with my GP trainee hat on. The MSF feedback is hugely indicative of trainees that may have difficulties in the future if they're not able to work as part of a team. It's not just about including these pieces of evidence, but it's about reflecting on them and pulling out what you've learned from doing it. So just popping in a significant event analysis or the minutes from a meeting isn't quite enough. What was the learning? What's been the impact on the practice? Same with the patient satisfaction questionnaires. How was it doing that? Was it a bit daunting? Do patients perceive you as you thought they would? Just try and pull out the learning from each of those situations. We are aware that we need to develop supervisors to support you. And as Katie said, there's a lot of work going on in terms of advancing practice supervision, and we have the supervision and assessment leads now in post at each faculty for advancing practice in each region, which is brilliant. And you're probably aware that there's a lot of work going on to train up roadmap supervisors to support the various roadmaps in primary care, and they are being trained up so that they can support FCP through to advanced practice. So if they're in your area, they will be able to help you going forwards. One of the things that your portfolio is also good at catching are those level 7 masters level behaviours. These can be quite difficult to capture. What are they? What do we mean? And it's about that ability to be able to use your initiative, come up with solutions rather than problems, and be able to make those decisions in challenging situations, and to be able to manage uncertainty. And that uncertainty might be your uncertainty as a practitioner, but also patients' uncertainty. Patients' uncertainty about what their presenting problem is, or who they're actually seeing in practice today. They haven't not seen the GP, so is this going to be okay? So there's a lot of uncertainty to manage, and the ability to be able to take control and take ownership of your own learning and developing your own capabilities is key, as is working as part of that wider multi-professional team, particularly as things have developed in the last 12 months where modes of communication and consultation have changed hugely. Just to have a little focus on the clinical capabilities to start with, and I think it's probably fair to say that this is where people start off. This is where your employers and your practices want you to focus initially. This is about doing the day job. So in the back of the many of the frameworks, the primary care nurse one, for example, you can access a whole heap of portfolio tools. and workplace-based assessments and others. And in the roadmaps, there are also the tools there available. And the top two there, the COTS, mini-KECs, and the KEPs, which really are the primary care ones, tend to be DOPs in secondary care. That's really about observed practice, somebody seeing you in action, seeing how you interact with a patient, gather your history, undertake any kind of examination, come up with a shared management plan. How do you do that day to day? And you're able to get feedback and have a bit of an action plan and some evidence in your portfolio from those. The third one, the case-based discussion, is much more around providing you with the opportunity to demonstrate how you think about things, your clinical reasoning and critical thinking skills, and pulling out the knowledge and how you're applying it day to day. Obviously, we've talked about the multi-source feedback and the patient satisfaction questionnaires. Key to include our colleagues and patients in feedback about our practice. Personal development plans, there are examples of those. You can add the bits and bobs on if you've identified gaps in your learning, then you can add those to your personal development plan, and it's a way of helping you pin down what those learning needs are. I mean, many people use puns and DENs as patient unmet needs and doctors' educational needs. They're very popular in primary care, and they can help you to put those onto a PDP so that you've got a bit of an action plan about how you're going to address them. The reflective learning log, I think I can imagine lots of people rolling their eyes when I talk about reflective learning logs. We're not talking about reflective essays that you might have to do 3,000 words on. The reflective learning logs as part of your portfolio are really about you capturing the learning from day-to-day interactions with other people. And it might be that you have seen a patient and were absolutely delighted that you'd read those particular NICE guidance 2 days before and you felt really confident and capable, and you reflect on that. Or it might be the other end of the spectrum where you've had someone come in and you felt way out of your comfort zone. How did you manage that situation? What did you learn from it, and what impact will it have on your practice going forward? So it's not lots of description, it's just really a tool to help you pull out the learning from your day-to-day practice. And the last bullet point there around clinical supervisor report. So to get some very structured feedback from your supervisor within practice. And again, there are templates of those available. When we look at the research capabilities in the multi-professional framework, I think people think they've got to go off and do a big, long doctorate, and a bit sort of scared by it all. And it's not necessary. People might do. There might be people out there that are really keen on undertaking research and writing papers. That's absolutely fine. Might have practitioners that work alongside an HEI and do a bit of lecturing at university and involved in research that way. But I think for most of us, it's around being very much aware of the evidence-based practice for our scope of practice in the role that we have, and also the whole kind of quality improvement activity and an audit and improving patient pathways and improving your own practice. So this is about being able to improve as a practitioner yourself, but improve pathways and experiences for patients and work across systems. Going forward, I think there will be new ways of working. There'll be opportunities to maybe work in primary care a couple of days a week, and maybe in community or secondary care. And when you work across settings, there might be more opportunities to look at pathways and improve quality. So how do you capture this in a portfolio? Well, if you're going to do an audit, you'll have data collections. You can include those. You will have to analyse that data, talk about why it is that you've looked at it, why you want it, share the learning from that, and look at how you're going to improve that quality. So if you have devised a new patient template or a patient information leaflet, then you could include that in your portfolio, because that's your impact on practice and almost the legacy that you're leaving behind after you've done that piece of quality improvement work. Think about what it is that you're changing to improve things for practitioners and patients going forward, and include that in your portfolio, and again with a bit of a reflection about what you've learned from the process. Similarly, for educational activities, there's a lot to think about in terms of you as a practitioner and looking over at your own development and your own CPD, but how you support the development of others. Supporting more junior staff, maybe from a uni professional point of view, where you are talking to your own profession and developing them, and also developing fellow first contact practitioners or advancing practitioners within primary care and wider. So you might be working across a PCN or an ICS, and you might be doing that, as I say, uni-professionally or interprofessionally. Again, engaging with HEIs or training hubs or training teams elsewhere. This is certainly something that we're doing in my region in Derbyshire. We're looking at pooling all of our educational resources across the system so that all of our advanced practitioners, regardless of which clinical setting they work in, can access the education. So when my colleagues in the community trust put on sessions, anyone can access those, and we've put on some sessions in primary care, and again those are shared across. We're now currently looking at developing educational opportunities where there are gaps. So one of the examples, one of the areas we're looking at is intimate examinations, because they're not really taught on advanced practice programmes. So we want to be able to plug that gap and offer some training for people across the system with key bits of sort of anatomy and physiology and process type things, but clinical presentations that vary depending on the setting that you work in, so that you make it really appropriate and useful to your own workplace. And there's a group of advanced practitioners that are working on that to put that together. So that's something that you could become involved with as a suggestion, and then evidence in your portfolio. Again, we've talked a little bit about the roadmap supervision training. Once, if you have full masters, or once you're on the directory as a recognised advanced practitioner, you can undertake the roadmap training and become a supervisor and help to supervise and assess others. And that's really a lovely way of sharing your own learning and developing the team. And remember that the regional faculties will be doing lots, so if there's anything that you can do support, I'm sure they would be very pleased to hear from you. If you are going to be involved in teaching, if you work as part of a training practice, for example, you might be involved in delivering tutorials to multi-professional teams, undergraduates, postgraduates, a whole mix. So if you're going to come up with a teaching plan, that could go in your portfolio along with an evaluation of your teaching. Get some feedback from people and reflect on that. And if you were doing a teaching project, you might want to do a multi-source feedback to the people that were involved in that, and get some specific feedback again around your educational capabilities. From a leadership and management point of view, again, you might be leading on a particular area. Maybe there's an area of QOF that you're very interested in and you want to lead on. So an example from my own practice, one of my colleagues has taken on leading on learning disabilities. So she has just enjoys that and takes the lead in sorting out all the learning disability reviews, going to the learning disability care homes, really enjoys that piece of work. It's freed up one of the GP partners to do something else. She's looking at how to improve processes and make things better for patients, get better take up and better understanding of our patients with learning disabilities. So that's been really positive, sharing that across the PCN. You could share a meeting or a forum. There's many forums that are being set up now, particularly in primary care, but also wider to link in with other settings. So involvement in that would be a really good way of demonstrating your capabilities. Some of you might like to stand up and speak at conferences, although we're doing less of that now and talking on Teams, but either of those would count. You may be experts in your field with your own superpowers of your profession. So actually being able to lead on that and share that would be huge. And again, you can use the various tools to evidence that in your portfolio. It's a little bit sort of fake looking at this all separately, but sometimes it helps to when you're looking to evidence things in a portfolio. In reality, if you were running an audit, you would share that learning with your colleagues. You might then lead on change. But your portfolio might look a bit weak if you had one piece of evidence to cover all of those. So it's thinking clever. You will do lots of things as part of your everyday practice that you just need to be able to capture somehow and get down in your portfolio. Essentially, I would say there's so much happening at the moment. There's so many developments, the credentials piece, the accreditation of programs, the portfolio route, the portal coming out. None of us know exactly what's going to have to be uploaded to the portal. But if you are spending some time developing your portfolio in the ways that we've discussed this evening, none of that's going to go to waste. And it really is your opportunity to shine and show people what you can do, evidence your capabilities and the way you work day to day. Be proud of it and don't be worried about saying, well, actually, I can do all this really well and there's a bit of a gap here and I can plug that gap. I can work out how to do it with a bit of support. It really is an opportunity for you. See it as a supportive process if you can. At the end of this, what we want is for you to get recognition from the HE Centre and get your name on that directory so that everyone can see that you've earned the right to be there. I think that's all I've got to say this evening. So thank you very much for listening. I will stop sharing my slides and hand you back.
Thanks. I think everyone will find that really interesting. I think as Julia pointed out, it's about thinking about what you do. We're quite bad at reflecting on our own practice and what we've achieved. We just continue to develop our skills. We just keep going and we just do it day to day. And it's very rare that we actually take a step back and review, well, actually, what am I achieving? What am I doing? And putting it down and actually acknowledging what you've actually able to achieve. So some areas may need to look at and explore and discuss with your practice managers and go, I need to look at developing this, but actually you can probably map against all of the capabilities quite easily. Don't see it as a daunting thing. See it as a way of really demonstrating the skills that you have. And that's how it will then lead to your development. And it could actually enable and facilitate those kinds of discussions where you look at, are there areas that you want to develop? When was the last time you reviewed your role and where do you want to go? It opens up those kind of conversations because you say, these are the breadth of my knowledge and skills. Is any of it being underutilized? Have that conversation, but to actually have it documented down really enables that. So, I was a practitioner. I was before this role, a consultant and therapy radiographer. I'm used to the ACP pathway. I'm used to the documentation. We're all used to portfolios and credentialing. It's nothing new. It might be in a slightly different format, but it is definitely not new. CPD, we know we need to evidence. We also know we're all pretty bad at doing it. And when it comes to that renewal, we suddenly kind of get everything, in order. But this is just demonstrating your skills and everyone's able to do that. So thank you. I think it was really useful to see the different types of evidence that you can use to do that. So I will hand you over to Marie. She's going to be your main contact within primary care, and she can just explain a little bit about her role.
Thank you, Julia. Thank you, Katie, for those really comprehensive presentations. So my name's Marie. I'm the Advanced Practice Lead for Primary Care, and I thought I'd take this opportunity just to share with you a little bit about my role, what we're currently working on and any support I can offer you. So I've been working in the main with the advanced practice leads from each training hub so we can understand the various roles that you as ACPs are working out within primary care, your current qualifications and any needs or interests in undertaking any further academic study, as well as identifying any additional training and development needs outside of any education formal programmes. I've been working with the training hubs to support them through the commissioning process, so that's for education places on MSc or top-up programmes, and we've been working to develop a repository of resources which set out the different training pathways, the routes to seeking recognition with the Centre for Advancing Practice. And I've also been working closely with our regional supervision and assessment lead to support and develop ACP supervision and increase capacity of our educators from our multi-professional background. So if you're currently a trainee ACP, you're on a programme, you're new in your role or established, or thinking of training as an ACP, I'm able to offer you that one-to-one support in relation to, for example, developing a portfolio, understanding the frameworks, the routes to recognition, the training pathways, or if you just need a space to reflect and have a discussion and seek some guidance. Coming up, we've got our second webinar on the 9th of September, which is at lunchtime. And in October, I'll be running some one-to-one drop-in sessions. And I'll circulate those dates via the training hub as soon as they're finalised. I can be contacted via the regional faculty, via the primary care school, or of course via my direct email, which we can share following the webinars. Thank you. So I think we're now going to move over to some question and answers. And Kashka, you have Slido.
Yes, I do. Unless my computer's very bad at updating, we don't have any questions in the Slido.
Oh, well, that makes it an easy webinar. So I'll open it up to everyone. Obviously, we've bombarded you with quite a lot of information this evening, and this is your time to kind of ask us anything, really. We may or may not have answers. We can come back to you, but we do kind of have an idea of what's going on. So if anyone wants to put their hands up or pull it in the chat or Slido. So Sarah Jane, now this is where we might have to unmute you, or Kashka needs to unmute you. I'm just going to see hands.
I have unmuted you. You might need to unmute yourself, but I've enabled your microphone.
Hi, it's just a question when we're looking at the portfolio, etc., about how many pieces of evidence and how far back we can evidence, because if all of a sudden we're trying to put all of these portfolios together, how far back can I say that, you know, I've had a case-based discussion with my tutor or my trainer. How much of that can I put into my portfolio and timescales, really?
Do you want me to go? Regarding evidence, that at the moment that we don't have that guidance. If you look at other accreditation credentialing, they say between 6 to 8 evidence, which would evidence across the 4 pillars, but we're still waiting on the HE Centre guidance on that portfolio of specific numbers. For the length of evidence, generally it needs to be current practice. So anything over a few years old can still be used as long as you reflect on how you currently use it in practice now. So if it's an older case-based discussion, if you just put that in with no new reflection or anything that's been developed, it probably wouldn't be deemed acceptable. But if you then go, this is the case-based discussion, this is how I'm currently using it in practice, have you amended anything since then or changed anything, or are you happy that it's relevant to current practice with current guidelines, and it's just making it relevant to your practice current now if it's an older piece of evidence. And the same with older master modules or your MSc, it's all relevant, it's all knowledge and understanding that you have gained. The key to any portfolio is how are you currently using that in practice now. and how is it improving your patient care, your service improvements. It's having that kind of reflective and bringing it up to date. That's what they'd be looking for to see within that portfolio. Julia, Marie, do you want to add anything?
Yeah, I think as Katie said, some of us did our masters a very long time ago. It doesn't mean that none of that's relevant, but it does mean that we've had to do CPD and read new guidance and learn to apply things differently in our day-to-day practice. So absolutely agree with making sure that your evidence is current. I think in terms of numbers of pieces of evidence and things, it's very difficult. We've been able to give a guide in some of the roadmaps. We don't set that out in the broader frameworks, but if we look at medical training, you set a minimum and everybody goes for the minimum, and that's a bit high risk. You have to look at the capabilities in the framework and see if you have evidence that meets all the capabilities. So if we look at the nursing one as an example, there's loads in there, but what we need to see is that you are able to take a good history from a patient and rule out red flags. And it might be that some people can evidence that quite clearly in 4 pieces of evidence, and somebody else might need 12 pieces of evidence, because we all work differently and have a different starting point. So try not to think of numbers if you can, and try and think about, have you got evidence of capability in your portfolio, so that somebody else would look at it and say, yes, I'm happy that this practitioner would see my friends and family. I think that's a really good test.
Lovely, thank you.
Okay, we've got another hand, and we've also got some questions in the chat now. So the hand is Lucy. I'll enable your microphone. Give me just a second. You might need to unmute yourself.
Oh yeah, can you hear me?
Yeah, we can.
Thank you very much. That was really interesting. So thank you. Can I just ask about the supervisors? That's what I'm keep being asked quite a lot. Who are, how do we find out who are? Apparently, I know we were speaking to Layla, we said there are some in the East. Is there a way we can?
Sorry, Lucy, you're really quiet.
Oh, can you hear me now?
That's better. Perfect.
Yeah, sorry. Moving my mic around. It's just about the supervisors, how we can find out who they are and how we can contact them, and about the training as well, because I don't think there's many supervisors around. Or are there? I believe there are a few in our area, but it was just really how we can find out who they are, because that's what everyone keeps asking.
So shall I answer that for you? So yes, the roadmap supervisors specifically are increasing in numbers. We've got 500 plus now across the country, and that's going up all the time. Your your training hub leads essentially will have that information. I can see Layla's got her hand up. She's probably desperate to come in and update. So the trainers, the national trainers, are training up more roadmap supervisors, and there will be a directory of roadmap supervisors, but your regions will have the names of who they have who've completed that 2-day training programme. I'm sure Layla will top up that answer.
Thank you.
If Layla can.
She should be able to now. She was muted. You just need to unmic yourself, Layla. I've enabled your microphone now.
I see, we don't want you to come in, that's all it is. Technology, it's failed.
I'll try to figure out the Layla button. In the meantime, we've got another hand, but we've also got some questions in the comments box. So we have one about if the CQC, what is the CQC position in terms of monitoring compliance of recognition of advanced level competence?
So the centre are working very closely with CQC at the moment, and it was CQC who had the concerns about the professional liability and organisational liability. So they are working to look at what would we assess organisations against regarding the governance of advanced practitioners, and that's where the directory has come from as well, to show those minimum standards are being met. So it's in development. It is on the CQC radar, and they are wanting to develop a set of criteria that will enable organisations to be mapped against and to ensure that advanced practice is implemented safely and effectively for patients. Again, as with everything at the moment, it is in development. But when I'm talking to the ICS leads, the CEOs and organisations, I am making them fully aware that yes, this is going to be part of their processes going forward. So it does give us a bit of breathing space to actually start putting that governance in place to ensure that people are starting to register with the directory, identifying gaps within educational and learning needs, and starting to put action plans in place. As long as there's action plans in place, that's fine. As I said before, the guidelines have changed, and we know there's a lot going on. So it's about being supportive in helping practitioners to meet those guidelines, and it's about being supportive, certainly from my point of view, from faculty, to the organisations about how do we embed appropriate governance, how do we ensure that roles and responsibilities and that accountability framework is in the organisation to support trainees and ACPs going forward. So it is a work in process, but yes, it is very much, it's coming. I just can't give you a time frame of when it's coming. And I think, Layla, you might be able to talk now. Or not. Oh, do you want to put it in the comments box? Sorry, Layla. I don't know why it's not letting you play. Does that answer the CQC question? Does anyone want to follow up on that?
I think, Katie, you've answered that very well, and I would just say from a practitioner or an employer point of view, if there's a nationally agreed pathway or capability framework and you're not following it, then it's quite a high risk strategy. You'd need to, it would be sensible to be looking towards supporting your practitioners to do so. And as you say, CQC will be looking at asking questions around this in their inspections going forward, so we'll have to watch this space.
Okay, we have another hand that isn't Layla. I'll still try and fix Layla. So I'm going to unmute Jennifer Aston. Sorry, I'm a bit slow. Too many people. It's slowing down my computer. So allow mic. Jennifer, you should be able to unmute yourself now.
Perfect. Yes, thank you. That worked. Hooray. Hi, Julia. Nice to see you. It really was a question around timing, and I know you probably don't know the answer, but it would be really helpful to understand when the template for the poor old people like me who are having to do the portfolio route will come out, because and whether there will be guidance matched to the credentials, so you can say, right, okay, here's the 4 pillars. This is more for other people, because I do understand quite a lot of this, but how is this all going to be made easy for those people who are going to go, whoa, I don't want to do that? Because when I first went on the HE directory and signed up, they said, oh, it's going to be 3,500 words. And I'm going, whoa, I don't want to do that. So really, just can we have any idea? Autumn is now, really, sort of summer. But it'd be helpful to know when. And I just quickly, to give a side on CQC, I was talking to Elaine Biscoe, who's the nurse lead for CQC, the other day. And one thing I would say that would be really helpful from a national perspective is to give some easy checklist for CQC. So if we help them, I do inspections, so I do understand a bit about it. If we can offer the CQC a nice simple checklist, they would be delighted to make it easier for those who are doing inspections, because they're going to be very different now. They're being done virtually, mainly, a lot of them. So sorry, the question was around the template, rather than me waffling on, any time scale for those poor people like me doing portfolios.
So with the portfolios, the tender bids from the HIs and professional bodies have now all been collated. I've spent my last 2 days going through all of those bids and to look at the commissions and where they're going to, who's going to meet the specification criteria. So realistically, we should hopefully have that all approved beginning of September. It will then be letting the HIs or professional bodies aware of that. I think the initial scoping will be October realistically, because we're going to have to make sure that how it's looking is that practitioners would submit via a portal on the HE Centre, and that will then either say yes, you fit into the supported portfolio route, or not. So we'll ask you for some key information from the practitioner. So the practitioner needs to actively do this, and then if they meet that criteria of the supported portfolio route, they will then be directed to the HIs or professional bodies who have won those tenders. So I do think it's likely to be October, and dependent upon the HIs will be dependent when that first learning needs assessment gets done. So those that are then on that portfolio route and they say yes, they will then have a learning needs assessment with whoever wins those bids to go either, yes, you have the evidence and we're happy for you to submit it by the portfolio and we will then sign it off, or actually no, we think you might need further supporting information. So maybe it's further academic skills, not necessarily an MSc module, but within this supported bid we have got funding to support one MSc module. So that learning needs assessment will be done, discussed with the practitioners, and a plan put in place to support them to be able to submit, and ideally what we're saying is within a year period. But some people, like I said, if you've done credentialing or accreditation, you're going to be in a really strong point to know this is the kind of information that they need and will be accessing. So it's about having that supportive. I can't give any more definitive timeframes. I do think it will be October by the time that, from a faculty leads point of view, we've discussed with any of our HIs, we've got that process in place, and then we then come out. What I've constantly been asking for with the centre is when that portal and that e-portfolio goes live, it needs to have supporting guidance with it. And we've been pushing for that. We haven't seen it yet. They are promising that it's going to be there. We understand that practitioners need to have some guidance about what is going to be required. And I'm hoping from the feasibility studies, they are planning to kind of show this is kind of, you know, a portfolio that obviously not directly the whole portfolio, but this is the type of evidence that was included, which was a strong portfolio, which is one that was actually put on the register easily, and that kind of information going forward. So, like I said, as soon as we hear anything, we will let you know. But I do think it will be October before we come out to you. In all honesty, Julia, would you say anything different to that? Yeah.
No, and I think. It's a waiting game, so don't waste time while you're waiting. Just get some evidence together, because it's likely that you'll be able to use that to submit with very few tweaks, I would imagine. And
as far as I'm aware, you'll be able to scan it through, so it doesn't matter in what format you're collating this. Now, I do know that on the e-portfolio, when we looked at the clinical evidence, that those templates will be on there as well, so you could use those directly. But yeah, you can start submitting that evidence now. As a minimum, if you haven't got a professional credential or specification out there, go back to the 38 capabilities that are in that more professional framework, and you'll find that there's a lot of evidence that can actually map against multiple points of those. You know, you're not going to need 38 pieces of evidence to map against every individual capability. You'll have some piece of evidence that will actually map a broad range and demonstrate your breadth of knowledge and understanding in those. So it is, like you said, it's being clever with the evidence that you use and how you reflect on that going forward. And as you said with CQC, that's exactly what the centre is trying to do, is that checklist. What should they be going to organisations and practices with to go, we want to see this, this and this, what have you got in place, who are your trainees, what have you got, and kind of pull that forward. So that's the plan, and it's good to hear that is probably the best way going forward as well. Thank you.
Okay, So we've got a couple more questions in the box, and we've got one Slido. Michael Leary has asked, are there pathways available for people who don't have level 6 or 7 experience to be brought up to that level and then join the pathways?
Depends on what you mean by level 6. Are we talking banding? It's always difficult with academic levels banding, or agenda for change and all the rest of it. Essentially, the portfolio route is there. You can start uploading evidence. I think in the future we're going to be looking at people starting to upload evidence and keep on going as a cumulative sort of bank of evidence, and when they reach the threshold to be recognised at a level of practice, that will happen. So don't let it stop you. If you're working at you think at the right level of capability in practice, but you haven't got an academic module, that doesn't matter. It's about evidencing it. And I think one of the key things is being able to evidence your complex clinical reasoning skills, and the fact that you know what you think about to collate your data gathering and to come up with a management plan for your patient. And that can be quite a challenge when you haven't done it before. But as Katie said, the hope is that there will be templates and there will be examples. And certainly from a first contact point of view, there's the landing page, the roadmap landing page, and there are some examples on there, and that's building all of the time. And we hope, I'm sure, similar things will be happening to support advanced practice submissions as well.
And I think from the academic point of view of 6 to 7, it's that the difference with the masters, which is what you would need to demonstrate within the portfolio, is that critical reasoning, the analysing of data and reflecting on it, and how you improve your practice or your patient care or your service improvement. It's not taking evidence as fact, it's about being able to analyse it and critically evaluate it. That's what makes the difference in that jump. So if you had no level 7 academic, you may struggle, I think, to produce the portfolio to the level that you would need to demonstrate an advanced practice role. So it may be worth looking at what would be the way of kind of developing that. Are there specific modules that maybe, again, have conversations with your practice managers or your clinical supervisors? What evidence do you need to show that you're working at advanced practice? But if you look at the more professional framework, it does say master's level or equivalent. So it is going to have to be at that level 7 that your evidence is being submitted by, but there are different ways. It doesn't all have to be a master's module. It's about how you reflect and build that evidence against the capabilities, but using all of those level 7 skills that you would have. So it's probably worth having that conversation with your supervisors and how you want to develop into that role.
Can I just add, Katie, there is a e-learning for health module under development to support complex clinical reasoning, and it's going to be in stages, so that you if you've never done a master's module, you'll be able to do part of this, and you can't get to the next bit without your supervisor unlocking it, so that there's a little, so it makes it interactive, and then it'll unlock. It's like a game show, and you can go to the next level, and evidence that you are able to use complex clinical reasoning skills and critical thinking skills in your day-to-day practice. So there's loads of things under development to support this, but it's all rushing forward at such pace. I think it's difficult to keep up, isn't it?
So we have some more questions coming in, thick and fast. We might have to answer some of these afterwards, but so there's a question from Chris Baskerville. I think the question is, if you're working towards an advanced practice role, for example, on the MSc pathway, should you also be working to complete the FCP pathway whilst doing it? Obviously, that could be superseded by the accreditation route.
It depends on the scope of practice and how you're employed with your PCN or the practice that you're employed by. Don't think of it as a waste of time, really, because the first contact practitioner knowledge, skills and attributes document is a subset of advanced practice. So you take that with you almost as a credential. You've got that unit of learning that you can use to evidence your advancing practice capabilities, and you have to top up those other pillars. So it's just a pathway towards advancing practice. That's why it's been designed as it has been. So don't think about it duplicating work. It should essentially, you just take it all with you in a suitcase to the centre and put it in the portal and top up the bits from the other pillars to get that recognition as an advanced practitioner.
And I think from my point of view of the advanced practitioners, if that's what you're currently doing, having that knowledge of the FCP frameworks and the roadmaps and what practitioners are required is also key, because you're going to be, when you're experienced and qualified, the supervisors for those FCPs. So understanding what they have to evidence and what they go through is vital, that you know that. So it also enables you to support that supervision and training going forward. So I would say it's really valuable, but again, be clever with your evidence. You can map against and use it for both. If you're doing it in your advanced practice, then you've probably got all of those FCPs already. And again, it will identify if you haven't, which is probably a good thing. I think the one thing we don't do is necessarily do that. Where's the gaps? And how, is there anything that I need to just have a look at? But I think you'll probably be able to map against. So I certainly, and I've spoken with Layla and we've had these conversations, I would recommend that you do that assessment part of it, because again, as you become then the trainees, you understand those requirements and what is needed, and it will help develop and support the workforce going forward, which is key to the advanced practice roles when you look at the education pillar.
Yeah, absolutely. It's creating a standard of practice in primary care, and it's all been cross-referenced to the primary care advanced practice credential. So there's been lots of cross-referencing that's gone on already. So as Katie said, it's all valuable evidence, and it looks at your capability as well as your level of practice. So it's really robust in terms of evidence for patient safety as well.
Okay, we're ready for another question. There's one on Slido about appraisals. In general practice, who do you think should run them for advanced practitioners? I know it's currently GPs. Should another ACP in region? Would that be another ACP that would do appraisals?
From my point of view, I think because of where we are with our supervision training, and still trying to understand where our ACP workforce within primary care is for the East of England, it's the most appropriate person within your practice who has the knowledge and skills to be able to sign off your capabilities. So if that's a consultant, which in a lot of cases it probably still is, then yes, they would be the ones to sign it off. No one should be signing anything off if they don't have those skills. And if you, again, when we talk about supervision, there's lots of different types of supervision. So there's your academic, there's your clinical, and your line manager may not be those either. So when it comes to your appraisals, more and more, it's more of a tripartite kind of conversation going forward with certainly when you're training, it should be your educational supervisor, whoever your line manager is, and then your clinical supervisor. When you're qualified, I would still say that you need a supervisor. Even as a consultant, I routinely met with my consultants as part of that process of what's going well, what you need to develop. Often it could be informal, but you still have that. So I don't think there's a one fit answer to that. The key is that they have the knowledge and the skills to able to evaluate your skills and be competent to sign you off. And again, this is about your patient safety. So it's ensuring that you have all of the skills, and if they don't, having that open and honest conversation of how you develop those. So it should be a two-way process, a very open discussion about where you're at, what needs to be developed. But I think as it gets more complex, it doesn't necessarily need to be one person, it could be multiple people. And from our point of view, as Leda pointed out, Marie, we are looking at that supervision workforce. We are looking at the medical and consultant having ACP training built into the East of England tiered programme. We're looking at actually developing a more professional supervision programme. So it could be other people, and it could. There is no reason why experienced advanced practitioners can't be those signing you off within practice as trainees. Like I said, as long as they have those skills. So it is early developments, but we are looking at it and trying to build that supervision piece going forward. And certainly within practices, probably via the training hubs, having that network of supervisors that you can kind of tap into to get that support going forward. But again, that's future plans and areas that we're working on.
And if I can just add about, if this is about appraisal, some of the appraisal documentation isn't hugely supportive of appraising across the 4 pillars. And that can be, if you get a GP doing your appraisal, they're more likely to focus on the clinical stuff, which is fine, but then you don't really get any feedback about the other areas. So it might be that your GP does it alongside somebody else, the ACP lead for the PCN or the region. And I think we've put an appraisal template on the landing page as an example, just for people to take and develop. It's not perfect, but it's a starting point for people to take and use as they go forward.
And I'm certainly looking at trying to develop a governance document. It will be broad, so all organisations will be able to amend it to what they need, certainly until the national governance comes out. In that, there's some really key things of your job description written and developed under the 4 pillars will then enable your objectives to be written under the 4 pillars, which means that you're actually acknowledging not just your clinical, but the other 3 pillars and ensuring that time is allocated to enable you to do that. Sounds really simple and a straightforward process, but it doesn't happen. We know it doesn't happen. So having some clear documentation and some templates to help that going forward. And the same with we've done like an ACP template of what should be discussed. So what are your capabilities? Is your prescribing up to date? Because obviously there's different regulations regarding that. Do you have an up-to-date job description? Do you have a job plan? And I know I might be pushing it a bit too far with the job plans at this point, but you know, we can dream and we're working towards it. So it's having all of those in place to then be able to have the in-depth and supportive appraisal that actually is worth something at the end of it. That's what we need, and certainly when you're working at this level you need that going forward. So again, we're working on it. We know it's not there currently, so it's about providing organisations with that to be able to then adapt it as needs be to the organisation, but actually these are the minimum standards that you need to be having within an appraisal, within a job description, and we'll get to job plans.
Okay, we have quite a few more questions.
Okay.
So the next one I can see from Sarah Jane Turner. I've started my portfolio with the roadmap capabilities. Which capabilities are the correct ones, HEU or FCP/ACPM ones? So
the capabilities in the roadmap, they, as I said, that they will take you from first contact to advanced practice. So certainly within the paramedic one, there's a top up quite clearly stated. They're not in the MSK one because the international MSK standards are being aligned with the advanced practice standards here. So they will be out with us soon. But for the other professions coming in, you'll be able to see the first contact ones and then the additional ones that you're needed to top up, and they align with the advanced practice frameworks from HE. So they're not separate documents, they are all aligned and intertwined, so don't worry. You can follow them. The first contact roadmaps are Health Education England, so it's all the same family, so to speak.
Okay. We have another question. So this is from Catherine Welch. If we have finished an ANP Masters in 2018, what should we do now to get on the register?
So I was going to say, I'd suggest that you look at the primary care ACP nurse framework that came out year before last. And it's quite clear all the capabilities there. So it's around making sure that you can evidence that you've got those capabilities. So it doesn't matter that you finished it in 2018. That's not that long ago compared to some of us. And actually you're working at that level. So it shouldn't take much time to show that that's what you're doing. So utilise the portfolio tools that are accessible in the back of that framework. That would be a good starting point. And I can just see another question that's linked from a nurse practitioner who did the nurse practitioner programme years ago. Again, if you're working at that level of practice, Carol, it won't take much. You just need to gather the evidence. So I would look to the nursing framework, use the portfolio tools and show what you're doing every day. And then if there are any gaps, you can address those. Okay.
And I'll just quickly answer Joanne's, which I think is the last question. If you're doing your MSc at Herts and it's the advanced practice one, I would say just hold off for the moment. Realistically, Herts will be starting to go through the accreditation process. We know they are. So realistically, you will fall into that category that will be uploaded onto the register because your programme would have been accredited by the HEI. So at the moment, that would be your action plan, and I think anyone, your manager, line managers should be happy with that, and that's something we are supporting. If you had a huge urge and wanted to do the portfolio on completion, then you can do, but realistically the easiest way for you is you will fall into that validation category. So you will then, even if they take longer and you complete the course sooner, you'll still fall into that validation, which means that you'll get onto the register.
I think we've got one more question in Slido, but I don't know if it's a question that you can answer.
That sounds like a good one to end on.
So it's an anonymous question. Does the panel think this is the end of in-house MSK physiotherapy treatment as the space is being used for FCP clinics?
So if I understand the question correctly, FCP is not the same job as physiotherapy. So if physiotherapy is still required and still needed, but working as an FCP, you are a diagnostic clinician referring on to physiotherapy if that's what's required, or referring on for further investigations and supporting the patient with self-management strategies. It's not about FCPs delivering hands-on physiotherapy. Physiotherapists do that. So hopefully that's helpful. It's an additional role. That's what we have to remember. It's additional. It's not in place of anything. Okay.
That's the last one that I can see on Slido.
Well, in that case, I just want to thank everyone for attending. I hope it's been useful. If you do have any feedback, obviously we've got the second webinar coming up. If you think there's anything else that we should be adding, please feel free to let us know via the faculty email, which I will just put in the chat box, but obviously it's part of the slides. And again, if you want to have that more one-to-one kind of conversation of where am I, where do I need to go, please feel free to use those drop-in sessions and we can have a more in-depth conversation, not on a whole webinar for everyone else to hear. Okay, so thank you very much. Thanks for attending. And if there's any outstanding questions left, then we'll pick them up and reply individually afterwards. But thank you, everyone.